are going to start the basics of ECG, just only 10 minutes, then we can go for the tachyarrhythmias. So in the first basics of ECG, we should know very small basic. What is small box and large box? There are two boxes we know. yeah right. So the first thing you have to know is, this is the basic ECG, we already know. So this is what is called as your small box and this is your large box. Let me just annotate. Right. Yes. Right. So this is what is a small box, right? And this big entire square is your large box. And each large box contains 5 small boxes, right? And each small box, if you take, each small box is 1 mm horizontal and 1 mm vertical. Very important. Right? So this is the basic calculation which we already studied since beginning. There is small box in ECG and large box in ECG, and large box contains 5 small boxes. And each small box is 1 mm horizontal and 1 mm vertical. And ECG runs at a speed of 25 mm per second. This is the very standard dictum. So it runs at speed of 25 mm per second. So if you see this thing, so 1 second, right, 1 minute. So what does it indicate? 25 per second. For 1 second, it is traveling 25 mm. So 1 mm is equal to 0.04 second. So we'll just put this thing. Right. So as I discussed, small box is 1 mm and also large box is 5 mm, and actually ECG runs at speed of 25 mm per second. That indicates what? 1 second it will cover 25 mm. Then if you see 1 mm, it is 1 by 25. That's almost equal to 0.04 second. So each small box is 0.04 seconds, and each small box in vertical direction is 1 millivolt. Right? Even though you don't remember any calculation, just only remember this thing. Each small box is 0.04 second and each small box amplitude is 1 millivolt. Right? So let us see this. So as I discussed, this is small box and this is your large box, this small box and this large box, and each large box contains how many? 5 small box. 1, 2, 3, 4, 5. 5 small box, and each large box containing. And each small box, if you take, definitely it is 1 mm horizontal and 1 mm vertical, and ECG runs at a speed of 25 mm per second. So each small box counts for 0.04 seconds in horizontal, and vertical it is 1 millivolt. Right? So this much is enough. So main thing you have to remember is only these two boxes. Small box, it is 0.04 seconds, and small box in vertical is 1 millivolt. We will see horizontally for time, vertically for the volts. Very important. Right? So then after this, a basic introduction about your conduction system. We already know it always starts in the sinusoidal node. It is your pacemaker. From the sinusoidal node, it will go to your this AV node. From the AV node, it's a bundle of fish. Then bundle of fish is a left bundle, right bundle, and this is a Purkinje fibers, and then comes your ventricle. So this is what your normal conduction system. About this thing, how this conduction system is represented in the ECG, we have to know about that thing. So let us see. Right. So this is a conduction system. As we discussed, SN node, as it depolarizes, atria will contract, and this is represented by P wave in ECG. Right. The atrial contraction is represented by P wave in ECG. Right. So once atria is contracting, now the depolarization passes through the AV node. It passes through AV node. So one of the problem is this AV node is a calcium channel mediated. Right. Entire myocardium, it is sodium channel mediated, but this AV node is a calcium channel mediated. Very important. It's a calcium channel mediated. So what is important of this point is this calcium channel mediated is very slow to depolarize. Right. So once atria is contracted, now depolarization current goes to the AV node. This AV node is very slow to depolarize. Now it goes to the bundle of fish and ventricle contract. Right. So from atria to the ventricle, it has to impulse us to go to the AV node, which is very slow. So there is a delay is there, and that delay is represented in ECG as your PR interval. Right. Is represented as PR interval. Right. That's it. Very important. So depolarization current from the A3 it goes to the AV node, but AV node will go slowly because it's a calcium channel mediated, and this slow and this delay is represented in ECG as PR interval. This AV node conduction is represented as PR interval. That is why in the case of first degree heart block, there's delay in the AV node pathway, so there is a prolonged PR interval. Right? Fine. Now from AV node to bundle of phase it will go. From bundle of phase it comes to septum. In the septum always it goes from left to right. This is again one more important crucial point. Okay, septum always depolarizes from left to right, and this is represented in your ECG as your Q wave. As your Q wave. Right? And then to right and left bundles, then to Purkinje fibers, and now ventricular depolarization. This ventricular depolarization is represented by your QRS complex. QRS complex. Simple. Right? And the last is your ventricular repolarization. It is represented by your T wave. Right? This is a simple thing. Right? Simple thing. So what are the different waves depicted in ECG? You have to know. SA node, it is represented. It causes atrial depolarization. That is represented as a P wave. And now after atrial depolarization can pass through the AV node, but AV node is a calcium channel mediated, so it's slow to depolarize, and this slow to depolarize is represented by lag, and that lag is called as PR interval. Then AV node conduction is represented as a PR interval. Right? Then go to bundle of phase. From goes to septum. In the septum always depolarization left to right, and the septal depolarization is represented as Q wave. Right? Then goes to ventricle. Ventricle is going depolarization. That is represented as a QRS complex, and then ventricle repolarization is represented as your T wave. Right? Right. Okay. So this is what I mentioned here. So POA represents your atrial depolarization. Yes, we know already. And QA represents septal depolarization, right? And the QRS represents your ventricular depolarization, right? And TWA represents ventricular repolarization. And PR indicates AV node conduction time. Very important points. Simple, very basic, right? Okay. Then goes to our next slide, right? After knowing this thing, some basic important thing: how to calculate the rate, how to calculate rhythm. Rate it is calculated by 300 by number of large boxes between two R waves. I will just show you. So this is your basic ECG here. So this is the basic ECG here. Right. So this basic ECG. This actually it's your P wave. This is your R, and this is your S, and this is your T wave. Again, this is again your R. Right? And rate is calculated by number of large boxes between two R waves. So this is your one R wave, and this is your second R wave. In between number of large boxes 1, 2, and 3, almost 3. So rate is 300 by 3. That is equal to around 100 per minute. Right? That is your normal heart rate in this ECG. So this is how to calculate the rate. One more thing they will say is 1500 by number of small boxes. If you can remember, you can remember. Otherwise, no need. At least just remember 300 by number of large boxes. Right? So here between two R waves, there are 1, 2, and 3 large boxes roughly. So 300 by 3 is 100. Then next is rhythm. In the rhythm, what you have to identify whether first thing is whether the rhythm is sinus rhythm or not. The first thing is sinus rhythm or not. How would you identify sinus rhythm? If there is a P wave, it's a sinus rhythm. The first thing here is you can see. Yeah. So if you see here, this is your P wave. So this is a P wave. So it contains P wave, it's a sinus rhythm. And second thing is regular or irregular. How will you say regular, irregular? Again, you calculate the boxes between two R waves. So these two R waves contains boxes 1, 2, and 3. And again, this also contains 1, 2, and 3. Every time it is same number of boxes between two R waves, then you can say it's a regular rhythm. If different number of boxes are between two R waves, then you can say it as irregular. Simple. This is again one basic step. Right? Right. So this is what we discussed. So rate is equal to 300 by number of large boxes between two R waves, and rhythm is either you see P wave indicates sinus rhythm, or regular irregular number of boxes between two R waves. So these are basic things. You all know all these things. So then comes this thing small again. What is the P wave duration? Again, this is what some people will ask you. So P wave duration indicates your every time remember in the small boxes. Large boxes don't get confused, right? So small box, I already mentioned each small box is equal to 1 small box is equal to 0.04 seconds. Just remember this thing, no need to remember anything. If PO indicates your 2 to 2.5 small boxes, that's why it is 0.12 seconds. Right? 2.5 to 3 small boxes, so it is 0.12 seconds. And QRS, it's very, very important. QRS 3 letters are there. It's only less than 3 small boxes. Right? Less than 3. If it is more than 3, yes, it is wide QRS. If it is less than 3, it is narrow QRS. And then comes a PR interval, it is 3 to 5 small boxes. Very important. Just 3 to 5 small boxes. Right? And QT interval, it is 10 small boxes. Just a basic small calculation memory point. You have to remember this thing. If you remember this thing, then only you will understand whether PR interval is normal, prolonged or short. QRS interval is narrow QRS or wide QRS, or QT interval is prolonged, long QT, short QT, you can know. Right? Simple thing. PO is 2.5 to 3 small boxes. QRS is less than 3 small boxes. PR interval is 3 to 5 small boxes, and QT interval is 10 small boxes. Right? Okay. So this is what I am discussing here. One important point we are discussing, what is interval and what is segment. So very important point here. Interval contains waves. Interval contains waves. Right? Segment doesn't contain waves. Segment don't contain waves. That is a very important point. So what is it? Just let us see in this thing. Right? So this PR interval means from the beginning of the P to the beginning of the QRS complex. So it contains a wave, that is your P wave. But PR segment is from the end of the P to the beginning of the QRS. So there is no wave. Segment doesn't contain waves. Very important. Right? Similarly, QT interval from the beginning of the Q to the ending of the T. This is your QT interval. Right? It contains waves again, QRS complex and T wave. But ST segment, it's ending of the QRS to the beginning of the T. ST segment, it's a segment, doesn't contain any waves. Interval contains waves, segment doesn't contain waves. Right? And always intervals you will measure in the duration, horizontal axis, but segments you always measure in the amplitude, vertical axis. Right? PR depression is there or not, ST depression is there or not, ST elevation or like that you will see. Right? PR interval prolongation is there or not, and then QT interval prolongation you will see. Right? Intervals always measured in the horizontal direction, and segments always measured in the vertical direction. Simply like PR interval from the beginning of P wave to beginning of the QRS complex, and PR segment from the ending of the P wave to beginning of the QRS complex. Similarly, ST segment from the ending of the QRS complex to beginning of the T wave. Right? And similarly, our QT interval is from the beginning of the QRS complex to ending of the T. Simple thing, right? Right? And last one, small important things we need to memorize here. We'll just see this thing. So what is called prolonged P wave, what is called as enlarged P wave. So prolonged P wave means duration is increased. Duration is increased. Right? That means horizontally it is more than 2.5 small boxes. More than 2.5 small boxes. So that is what is called as P mitral. Right? You see in the case of left atrial enlargement. So just see the ECG. If P wave is more than 2.5 small boxes horizontally, that is your P mitral. Right? Similarly, enlarged P wave means here amplitude voltage is increased. Voltage is increased. Right? Same way here there is 2.5 small boxes vertically. That is called as P pulmonale. You see in the case of COPD patients, right heart failure patients, mainly you will see pulmonary hypertension patients. So it's increased. It's called as P pulmonale. If it's enlarged, it's called as P mitral. Because you see in a condition of mitral stenosis, it's called P mitral. Because you see in condition of pulmonary hypertension, it's called as P pulmonale. Right? And prolonged PR, as we discussed already, if PR interval is prolonged, means AV node conduction is delayed. That means that is called as your first degree heart block. That is your heart block. Primary heart block, first degree heart block. Right? And shortened PR, very important here. You see in only one condition in your entire ECG, that is called WPW syndrome. We will discuss about this thing. Right? And prolonged QRS again, that means your broad QRS. Right? You see in the case of bundle branch block. Right? See from the left, from the AV node to the bundle of fish, it is going to the ventricles. If one of the bundle is blocked, it will go very slowly. So if it is going very slowly, ventricle also depolarize slowly. So your QRS complex will be prolonged. That is called as broad QRS. That is called bundle branch block. Right? And prolonged QT, you know already, it's more than 10 small boxes. Prolonged QT, you see because of some drugs like antipsychotics. You see in the case of some metabolic like hypokalemia, all these things. Right? And PR segment, we already discussed, from the end of the P wave to the beginning of the QRS complex. That's called PR segment. If it is depressed, only one sign is there in the entire cardiology. That is called as spodic sign. Spodic sign. This is again Viva question. So spodic sign, which you see in the case of pericarditis. pericarditis. And ST segment, whether it is elevated, it is called as ST elevated MI. If it is depressed, that is called as non-ST elevated MI. We already know about this thing. We commonly see in the casualty, right? And tall T waves again you see in the case of hyperkalemia, right? And you also see in the case of hyperacute MI. Right? Simple. These are the basic things. So what you have to do is just to go take the ECG, and the ECG what you have to know. So just someone please mute your audio. So someone please mute your video. Right. So this is the abnormalities of the waves, very important. So just to see the ECG, first thing you have to see ECGs. Right. So what you have to see is first see the ECG, see all the waves are correct or not, P is correct, QRS is correct, T is correct. Then you have to calculate the rate, then you have to calculate the rhythm. Right. So for that only you have to know the actual durations. So P is only less than 2.5 small boxes, QRS is less than 3 small boxes, PR interval is 3 to 5 small boxes, and QT interval is 10 small boxes. Right? Each small box 0.04 seconds. That's it. If you remember this thing, it's very easy. Just take a ECG, see the rate between number of large boxes between 2 hour waves. You can calculate 300 by number of large boxes 2 hour waves. Rate is done. Keep it aside. Then you see the rhythm. P wave is there, sinus rhythm, and same large boxes are present between 2 hour waves. It's regular, and different large boxes are present between 2 hour waves. It is irregular. That is done. Then you see each waves. So P wave you have taken. It is enlarged or prolonged. If it is enlarged, it is P mitral. If it is prolonged, it is P permanent. Keep it aside. Then you take the PR interval. If PR interval is prolonged, yes, it is first degree heart block is there. Usually we'll miss this finding in the ECG, but you have to focus on step by step. You have to go. Right? If PR interval is depressed, you see only one thing, WPW syndrome, which we'll discuss now. Then you see the QRS complex. If it is more than 3 small boxes, that indicates a bundle branch block. Very important. Right? QRS complex is more than 3 small boxes means the bundle branch block is there because of the depolarization going to the ventricle slowly. So ventricle is depolarizing slowly, so it will take time to depolarize. So it's more than 3 small boxes. That is your white complex QRS. Right? Then comes a prolonged QT. You can see from beginning of the QRS complex to ending of the T wave. There is a prolonged QT. If it is prolonged, you can see your drugs are there. Any metabolic like hypokalemia, all these things you can see. Right? PR segment depression. Only one finding, only one clinical condition you will see in pericarditis. There is a PR segment depression that is called as coding sign. Very important. And last is ST segment. You commonly see whether it's elevated or depressed. If it's elevated, STEMI. If it is not depressed, it is NSTEMI. And last is tall T waves. Tall T waves you can see in case of hyperkalemia or you can see in case of hyperacute MI. Right? Right. So this completes our basic thing. Right? And last one more small basic thing is there. You have to know the leads. There are so many leads are there. Different limb leads, chest leads are there. Chest leads are V1, V2, V3, V4, V5, V6. Limb leads are there. AVL, AVF, AVR. So many things to remember. No need to remember anything. Just only remember this thing, this slide. This slide is very important clinically. If any problem occurs in these leads, so that part of territory is involved. Right? So that's what important. So many things. If you take any ECG books and all, they will mention okay, limb lead is there. You connect one, you connect AVL. The connection comes AVL. So much direction, so much access they will put. It's very difficult to remember, I know. But for the practical course, you have to know only this slide. If you know this slide, you see the ECG. If any problem in these leads, that part of your left ventricle is involved. That's it. Right? So as I discussed, so one and AVL includes your lateral leads. So one and AVL includes lateral leads. So one, you are seeing heart from the lateral, AVL not seeing heart from the lateral. They're called as lateral leads, specifically called as high lateral leads. They're also called as high lateral leads. Right? That means if one and AVL any abnormality like ST elevation, ST depression is there, you can say some lateral part of the left ventricle is involved. Right? And 2, 3 AVF are inferior leads. That indicates if 2, 3 AVF show any changes like ST elevation, ST depression, you can say inferior wall of the MI is inferior wall of the left ventricle is involved. Right? And V1 and V2 they're just present on either side of the sternum. They're called as septal leads. If any V1, V2 problem is there, you can say septum has a problem. Right? And then this is help to localize the MI also. And similarly V1 to V4, V1, V2, V3 and V4, these are all anterior leads. If any problem is there in V1 to V4, you can say anterior part of the left ventricle is involved. Similarly V5 and V6 also are from the lateral part. They're seeing the heart from the lateral side, so lateral wall is involved. So combinedly V1, V2, V3, V4, V5, V6 all are called as anterolateral leads. Right? This is very, very important. Only just ST elevations are present in one AVF, you can say high lateral MI. If ST elevation is present in 2, 3 AVF, you can say inferior MI. If ST only V1, V2 septal MI, V1, V2, V3, V4 anterolateral MI, V1, V2, V3, V4, V5, V6 anterolateral MI, and posterior MI is never seen in the case of ECG because we are keeping leads only anteriorly. This posterior part of the left ventricle is being missed. So we have to do posterior ECG by putting V7, V8, V9 leads. This is what the question they are going to ask in your Viva also. So where will you put the V7, where will you put V8, and where will you put the V9? This is what the question they are going to ask. Right? So what you are doing is you are just keeping V1, V2, V3, V4, V5, V6 are there. There is no V7, V8, V9. So what we are doing is we don't want anterior seats. So we'll remove V1, V2, V3 and we'll put posteriorly. So where exactly you are putting V7? V7 you are putting as posterior axillary line. Very, very important. So V1 is putting posterior axillary line. You are removing the V1, you are putting at the posterior axillary line, that is your V7. Right? And V8 you are putting at your tip of the scapula. Your tip of the scapula. You will remove the V2, you put at tip of scapula. And then V9 you are put at what is called as exactly paraspinal region. So paraspinal region. Right, clear? So posterior wall MI you cannot identify in the case of normal normal 12 lead ECG. So for that you have to put leads which are facing the posterior wall. So those leads are called as V7, V8, V9. So what you are doing is you are removing V1, V2 and V3. You are placing those leads posteriorly. The position of these leads are very important. V1 you will put at posterior axillary line, that is called as V7. V2 you will put at tip of scapula, that is called as V8, and V3 you will put at the paraspinal region, that is called as V9. Right? Clear? Right. I think the basic parts are covered. If any doubts you can ask. Right? We can start with the basic tachyarrhythmias also. Any doubts till now? Any issues?
Sir, once you show me that boxes for QT and once that slide.
Boxes for the QT into this one?
इसके पहले.
के पहले. This one.
हाँ सर, इसमें I missed listening. QT interval कितने boxes sir?
So QT interval is from the beginning of the QRS complex to the ending of the T wave.
Yes sir.
Okay.
Like while we check for the interval, it should be normally how many boxes?
Normal 10 small boxes. So usually 400 to 450 milliseconds is the normal thing. Until 500 also we'll take the normal. If more than 500, we'll definitely take it as a long QT.
Okay sir.
Right, technically, theoretically, they will say 10 small boxes, but okay, we can go until 500 small boxes. It depends upon the females and the males. Right?
Sir, and just by watching the distance between RR and QT, they interpret it as QT is more. वैसा कुछ है क्या?
What? Just by?
Sir, they will observe like eyeballing method, just RR distance and then QT distance.
Okay.
And they see that the QT, if it is more than RR ka distance, that means QT is prolonged.
Yeah, that they can say subjectively, but this is properly documented purpose. Right, you are saying in terms of small boxes, in terms of duration also. Everything you have to say in duration wise.
Okay.
Right. So let's have a small gist of this thing. You went to casualty, you have taken ECG. ECG is in your hands. The first thing you have to do is identify the rate. So rate, how will you calculate? Number of large boxes 300 by number of large boxes between two RVs. 300 by 300. Done. Keep it aside. The next thing you have to identify rhythm. Rhythm is regular, rhythm is sinus or not. If P wave is there, it's a sinus rhythm. If large boxes are same between two R waves, that is a regular rhythm. If it is different, it is irregular rhythm. Khatam. Then you go for each and every wave. What is the P wave? What is the QRS complex? What is the T wave? Right? Identify leads. Identify the waves in each leads. Now see the duration of all these things. So P wave, it should extend only 2.5 small boxes. If it is more than 2.5 small boxes, either horizontal or vertical, it is abnormal. It's P mitral or P pulmonary. Further evaluation needed. Right? See the PR interval. PR interval should be 3 to 5 small boxes. That's it. If it is less, it is short PR. If it is more, it is prolonged PR. Prolonged PR indicates your first degree heart block, and short PR indicates your WPW syndrome. Right? Then comes your QRS complex. If QRS comes with less than 3 small boxes. If it is more than 3 small boxes, bundle branch blockage is wide QRS. So wide QRS again we'll discuss much more. Right? Then comes your QT. QT should be 10 small boxes or 500 milliseconds is the last. If it is more, you can say it's a prolonged QT. So prolonged QT you can see for the other causes. Right? After this thing, the only one thing is wherever you find abnormalities, which leads it is there, you have to see 1 and AV is there, lateral abnormality is there, 2, 3 AV inferior abnormality, V1, V2 septal, V1 to V4 anterior, V1 to V4 plus V5 plus V6 anterolateral, very important, and posterior you're putting V7, V8, V9, V7 at the posterior axial line, V8 at tip of scapula, V9 at the paraspinal region. Right? After completing this basic ECG, which you people all know, we will go ahead to the arrhythmias. Right? So shall we go ahead to arrhythmias?
Yes, sir.
Yeah. So before starting arrhythmias, please don't note down anything. Just listen to these 2 points. These 2 points are very, very important. Right? So before starting arrhythmias, the first point I want to mention you is in ventricular arrhythmias, any type of arrhythmias, ventricular rate is important. That's very, very crucial dictum point. Ventricular rate is important. That means atrial rate is never important. So what does it mean? Atria, how fast it beats, it doesn't matter to you. You are not at all bothered about this. Your bothering is ventricular rate. How much is the ventricular rate? So why? Because if more is the ventricular rate, the less is the ventricular diastolic filling. Accepted or not? If more is the ventricular rate, ventricular diastole is compromised. Right? If ventricular diastole is compromised, ventricular diastolic filling is compromised. If ventricular diastolic filling is compromised, ventricular output will be compromised. If ventricular output is compromised, your perfusion to tissues is compromised. Right? So that is the ventricular rate is always important. You have to control the ventricular rate. You will never focus on the atrial rate. This is the standard point. Right? So that is the reason you will just see in ECG, you will see between you are calculating, that's why between 2 RVs, how many large box cells, what is the rate you are calculating, because you are always focusing on the ventricular rate. You will never focus on the atrial rate. Right? For example, some patient is having atrial rate of 180. In atrial fibrillation, we see some patient is having 180. But because of AV block, only some impulses are coming to the ventricle, and if ventricle is contracting at only 100, okay, you're fine. Because ventricle is contracting 100, you are not having any compromise of your perfusion. Right? So that's very, very important. Only ventricular rate is important. It's never atrial rate. You have to control the ventricular rate. The main aim is all the atrial impulses which are generated because of arrhythmia, you should not allow them to reach the ventricle. Right? That is the main dictum. Clear? If this point is clear, we'll go to second point. This is the second point again, I'm telling you. Right. See this, let me draw a small, just like this. For example, if you consider this is a heart, you can put this as a heart. Right. So this is your ventricle septum. Right. And this is your AV node, and this is your atrial septum. Right. So just consider like this. Now let us see. Right. So one point I discussed is your conduction system, that is your SA node, AV node, bundle of his Purkinje fibers. All these are specialized myocardial tissue. They are specialized myocardial tissue. So because they're specialized myocardial tissue, their rate of travel is very fast. They will travel very fast. Right. So one important point I want to mention is if any impulse travel through the conduction system and depolarize the ventricles. Right. If any depolarizing current, if any current travel through the conduction system and reaches the ventricle, it will reach very fast because it's specialized myocardial tissue. So what will happen because of that? Ventricle will depolarize very fast. So because ventricle will depolarize very fast, you can see in ECG QRS complex of narrow duration. Right? That is what I mentioned here. If passed through the conduction system, you will have a narrow QRS. Understand this point? Right? For example, some impulse is there here from atria or something from some ectopic is there. Some impulse is generated. It goes to the AV node. Right? It goes to AV node. So it goes to the AV node. From AV node it goes to the ventricle and it is depolarizing. So what will happen? It travels very fast. So ventricle also depolarizes very fast. So you will have a narrow QRS. You have a narrow QRS. Right? We'll have a narrow QRS. Right? But same thing, if you see one more color I'll depict here. Right. If depolarizing current pass through ventricular muscle, this ventricular muscle is not a specialized myocardial tissue, it's normal myocardial tissue. So its conduction time is very slow. It slowly depolarizes. So ventricle also slowly depolarizes. So you'll see in ECG as a wide QRS. It's a wide QRS, right? You can see in ECG as a wide QRS. right? So this point is clear. Any impulse which passes through conduction system, it is a specialized myocardial tissue. It travels very fast, so it reaches ventricles very fast. So ventricle will contract very fast. So your QRS complex will be narrow in the ECG. But if any impulse passes through the ventricle muscle, so ventricular muscle is not a specialized myocardial tissue. It's a normal myocardial tissue. It travels slowly and depolarize the ventricle. So ventricle will depolarize lately. So your QRS complex will be wide. Right? So now let us see. So what are the impulse which will travel to the ventricular muscle, right? So any impulse which generates above the AV node, it travels to the conduction system only, right? For example, from the atria or right atrium or left atrium or from the atrial appendage, some ectopic focus is generated. It has to travel through the conduction system, AV node, bundle, Purkinje fiber. So I can say all supraventricular arrhythmias, they have to travel through the conduction system. So they will depolarize ventricle fastly. So they will have a narrow QRS complex. Can I mention that? Right? So I am saying all supraventricular tachyarrhythmias, they always travel through the conduction system. So therefore they will have a narrow QRS complex. Accepted? Right? But if the ventricular, if the ectopic focus is coming from the right ventricle or left ventricle, right? So then here it's from the right ventricle, it is generating its depolarization in the ventricular muscle. It is not traveling through the conduction system. It is traveling through the ventricular musculature. So it depolarizes slowly. So you will have wide QRS. So I can mention simply as ventricular tachyarrhythmias, they have wide QRS. Right? This point is clear. Any doubts you can ask here. If this point is clear, remaining understanding will be very easy for you. Right? See, what is arrhythmia? Some ectopic focus is generated. This ectopic focus is generated from the atria or the ventricle, right? So anything which is generated in the atria, right atria, left atria or appendage, whatever it is, it has to pass through the conduction system. It has to pass through AV node, then go through the bundle of fish, then go through the Purkinje fibers and depolarize the ventricles. And this, your conduction system is specialized myocardial tissue. It has the fastest conduction, so ventricle also depolarizes very fast. You will have a narrow QRS. But if the impulse generates in the ventricle itself, like right ventricle or left ventricle, it will depolarize the ventricle very slowly because its conduction is very slow. You will have wide QRS, right? So that's why I can simply say in a technical clinical terms, all supraventricular tachyarrhythmias have a narrow QRS. All ventricular tachyarrhythmias have wide QRS, right? So this box is very important for basic understanding. So clear? Any doubts in this point?
No, sir.
Yeah. So simple thing. So ventricular rate is very important. You have to control the ventricular rate only. Second thing is all supraventricular arrhythmias are narrow QRS. All ventricular arrhythmias are wide QRS. Yes, exceptions are there. We will discuss those things. Right. So let us see now. Right. So let us see one basic. By knowing this thing, you have to know all one thing. So let us see all tachyarrhythmias. If I say this tachyarrhythmias, right? So first of all, I saw the ECG. In ECG, it is tachycardia is there. Its tachyarrhythmia is there. I saw between two heart rate is more than 100. It is there, and it is arrhythmia is there. So I have to differentiate whether it is a supraventricular or ventricular focus. So I can just divide them into whether it is a narrow complex. I will just see the QRS complex. I will see whether it's a narrow complex or it's a wide complex. Right? So because narrow complex, I can leave it as origin is from the supraventricular origin, that is supraventricular tachyarrhythmias. Wide complex origin is mainly ventricular origin, that is ventricular tachyarrhythmia. Clear? This point is clear? Right. So now, if you take the supraventricular tachyarrhythmias, so where is the origin? Supraventricular means above the ventricle. Where is the origin? It can be from anywhere. It can be from the atria, right? It can be from the just AV node, or it can be from your even sinus node also, SA node also, right? So supraventricularly some ectopic focus is generated that can generate from the atria or AV node or from the SA node also. If it is SA node, I can say it as sinus tachycardia. No issue. I can say sinus tachycardia. Okay, right? And then if it is in the atria, I can label them as, you know already, any impulse generated atria is, one is atrial fibrillation, where in exactly left atrial appendage ectopic focus is generated, that is causing your all arrhythmia, atrial fibrillation, the common thing. And other is your what is called as multifocal atrial tachycardia, MAT, multifocal atrial tachycardia. It is also generated from the atrium only, it is causing arrhythmia, right? And then comes your AV node, the king. If ectopic focus is generated from the AV node, what will happen? The examples are your atrioventricular nodal re-entry tachycardia. Also, one more is atrioventricular re-entry tachycardia. Two things are there. We'll discuss everything. No need to worry. So first thing I am saying is, you see the tachyarrhythmia, you just differentiate into supraventricular or ventricular by just seeing the QRS complex. If QRS complex is narrow, that is supraventricular. If it is wide, that is ventricular. Right? In supraventricular means from the above the ventricle, ectopic is coming. That means either from the atria or from the SA node or from the AV node. If it is coming from the SA node, simple, it's a sinus tachyarrhythmia. If it is coming from the atria, either it can be AF or it can be multifocal atrial tachycardia. If it is coming from the AV node, it can be atrioventricular nodal re-entry tachycardia or AVRT. There are two things are there, right? So we have to differentiate all these things by seeing the ECG, right? Simple. The next, ventricle tachyarrhythmias, nothing. The origin is only ventricle, either right ventricle or left ventricle. Nothing much to discuss in that thing. The only thing is whether it is a monomorphic or polymorphic. That's it, right? So these are all the tachyarrhythmias you have. So now we have to delineate everything. We have to identify all these things. So this classification is clear. If you have this understanding, it's very easy to identify the ECGs. So this is the basic understanding I want to give you before starting the ECGs, right? Right. So let me repeat this thing, the very important thing. So introduction to arrhythmias, always ventricular rate is important, because ventricular rate is the one which is deciding your cardiac output, which is deciding your perfusion tissues. So your aim is to control the ventricular rate. Your aim is never to control the atrial rate, right? And second thing, any focus, any depolarizing current which passes through the conduction system will have a narrow QRS. That is, all supraventricular arrhythmias have a narrow QRS and all ventricular arrhythmias have a wide QRS, right? After knowing this thing, after seeing tachyarrhythmia, you have to divide into narrow or wide. Narrow means supraventricular, wide is a ventricular. So in supraventricular means it can come from the atria, it can come from AV node, or it can come from your sinus node also. If it comes sinus node, sinus tachyarrhythmia. If it comes from AV node, AV nodal re-entry tachycardia or atrioventricular re-entry tachycardia. Two things are there. If it comes from atria, it can be AF or multifocal atrial tachycardia. Then comes wide complex, only ventricular tachycardia from right ventricle or left ventricle. We can divide them monomorphic or polymorphic. That's it. So this classification is clear. I can go to the next thing.
Yes, sir.
Yeah. So now let us see how will you identify all these things in the ECG. So let us see this thing. This AVNR and AVRT is nothing but simple. It's also in clinical practice you will say as paroxysmal supraventricular tachycardia, PSVT. This is what this thing. Okay. So some people are already asking what is PSVT. This is what PSVT. So paroxysmal supraventricular tachycardia, PSVT. Right? Okay. So after knowing this concept, after knowing this basic, we'll just go how to identify all these things. Is it getting recorded? Okay. Right. So just note down this flowchart. This flowchart is very important. So you have seen the ECG. In ECG you are seeing some. In ECG you are seeing some tachyarrhythmia. Right? You saw tachyarrhythmia. The only one thing you have to do is, first thing you have to identify is, first you saw the ECG. ECG is showing some tachyarrhythmia. The first thing you have to show is what is called as whether it is narrow complex or a wide complex. Right? Narrow complex or wide complex. Simple. So let us start with the narrow complex. In narrow complex, next thing you have to see is whether the rhythm is regular or irregular. Whether the rhythm is regular or irregular. Simple. If you follow these 3-4 points, you are able to appreciate or you identify all the ECGs. right? You saw the ECG, you saw the tachyarrhythmias. The first thing you would say is whether it's narrow or wide. If it's narrow, it is supraventricular. Wide, it's ventricular. After identifying it's narrow, you have to see whether it's regular or irregular, right? After seeing identify regular, irregular, then you see one more point that is called P wave. If P wave is present or P wave is absent, right? Similarly, in irregular also you have to see only P wave, whether P wave is present or P wave is absent. Right. P wave is absent. Simple. Oh, shit. One minute. No, it's not. One minute. Whenever we start PPT, some technical points will come. Just 2 minutes. Right. Right. So let me write again. So you saw some tachyarrhythmias, right? Even tachyarrhythmia, you have to identify whether it's a narrow complex, narrow QRS, or wide QRS. This is what we are discussing. So in narrow QRS, what you have to see is next step is you have to go for whether it is a regular or whether it is irregular. Right? If it's a regular, again you have to go for whether it's a P wave is present or P wave is absent. Similarly, irregular, whether it's P wave present or P wave it is absent. Okay. So this is what you have to follow. If you follow this thing, it's very easy to understand. Is it visible? No issues?
Yes, sir, visible.
Yeah. So this is what I'm saying. So just you saw the ECG. In ECG, you're seeing some tachyarrhythmias there. First identify, don't panic, see the QRS complex. If it is narrow or wide. Narrow, it is supraventricular. Wide, it is ventricular. We'll deal about wide later. We'll come to narrow. It is supraventricular identified. Then you see the regularity, whether it is regular or irregular. We'll come to regular, right? If it is a regular, okay, it's a regular only. P wave is also present. Mostly your diagnosis is your sinus tachycardia. That's sinus tachyarrhythmia. Nothing to do much. No need. Okay, because of anxiety, fever or something and all, it's just a pain, fever, anxiety, all these things will cause your sinus tachyarrhythmias. Nothing to worry, and correct the underlying cause. Right? If it's narrow, if its PO is absent, that is your paroxysmal supraventricular tachyarrhythmia, PSVT, very, very important thing. Right? And as I discussed already, PSVT includes some AVNRT and AVRT. Right? Then now comes to the irregular. You saw the ECG, narrow complex is there. It's a tachyarrhythmia, narrow complex. You saw rhythm is irregular. Then you again go for PO present or absent. PO absent, you already know it is atrial fibrillation. Simple. If PO is present, it is your multifocal atrial tachycardia, especially in a patient has history of COPD. That's it. Right? Clear? This flowchart is clear? You can identify every ECG based on this thing. Right? So tachyarrhythmia is there. You just identify narrow or wide. If it's narrow, yes, it is supraventricular. Out of supraventricular, how to identify? You see only 2 points, whether regular rhythm, irregular rhythm, and second thing is PO present or PO absent. Based on that, you can identify. If it's a narrow complex, QRS complex, if it's a regular rhythm, PO is present, sinus tachycardia. Narrow QRS, regular rhythm, PO is absent, it's a PSVT. That includes AVNRT or AVRT. Again, right? It's again narrow complex, irregular rhythm, PO is present, it's multifocal atrial tachycardia. It's narrow complex, irregular rhythm, PO absent, it is atrial fibrillation. Classic, hallmark. You won't go wrong. Even an emergency situation, patient is even suddenly in front of you, you can see the ECG, you can throw ECG, it's AF. You can throw ECG, say PSVT. It's just as simple as that. Right? Understand the concept. If you understand the concept, apply the concept in this flowchart, it's very easy to remember. Even in the sleep, you will say. Right? So after knowing this, we'll go for the wide QRS. We discussed only about narrow. So we are discussing about the wide QRS. Same way, we saw some